Good evening.
Today, my topic, 3 questions are there, sir.
Ah,
First is anesthesia and dental chair,
hmm.
chronic regional pain syndrome, and Glasgow score in pancreatitis.
Okay.
Coming to the first topic, anesthesia and dental chair, the topics are divided into history, problems of dental anesthesia, and what are the various anesthetic techniques available for dental extraction. Coming to the history, brief history, the first general anesthetic administered for a dental extraction is credited to Connecticut dentist Horace Wells, used laughing gas induced anesthesia. He underwent extraction of his own wisdom tooth by his colleagues under the influence of nitrous oxide. The following next year, he attempted to demonstrate this technique in Harvard. Unfortunately, the patient cried out during the procedure. However, during December 30, 1846, Sir William Morton exploited the properties of ether to facilitate dental extraction, and this agent was demonstrated to the public. Then the concept of general anesthesia as a means of performing painless dental work was thus born. However, around the turn of century, the local anesthetic was introduced, especially lidocaine in the year 1940, which changed the practice of anesthesia for dentistry. Over the course of 1970s, 1980s, there were increasing concern raised over the level of safety associated with this dental anesthesia, as it is a NORA, that is non-operating room anesthesia, that is which refers to the providing anesthesia care at any location away from the traditional operating room sites. Every year there were a number of deaths, often in healthy children undergoing simple procedures. So a workup party led by Professor David Posvillo made recommendations in 1990 for the safe provision of GA in dentistry outside hospital, which include avoid GA wherever possible, the same standards of personal monitoring equipment should apply whether the anesthesia is administered in the hospital or in dentistry, and the dental surgeries should be inspected and registered. These guidelines are revised in 1990 by Royal Dental Council and Royal College of Anesthesia. Coming to the problems of dental anesthesia, they are classified into patient-related and surgery-related. What are the patient-related factors? Patients are frequently children with all the attendant problems of pediatric anesthesia. Children may have frequent respiratory tract infections with an increased risk of airway problems. Some of the individuals may have learning difficulties, may often present for dental work under GA due to poor dental hygiene. These patients may be uncooperative and communication may be challenging. They may have other medical issues and physical abnormalities such as epilepsy, esophageal reflux, and cardiac anomalies, which should be dealt thoroughly. Next, patients are frequently anxious and they may have needle phobia. There may be increased high levels of autonomic activity with increased tendency to arrhythmias and vasovagal responses. And some patients may have delayed gastric emptying. Finally, patients are frequently treated as daycare cases, so with all the associated problems of ambulatory anesthesia. Coming to surgical factors, they are summarized as the airway, which should be shared by an anesthetist and dentist, and airway may be soiled with blood and debris. So during the procedure, any stimulation of trigeminal nerve during dental workup may be implicated in the increased incidence of arrhythmias seen in these patients. This tendency may be exaggerated by any degree of hypoxia, hypercarbia due to airway manipulations. Vasovagal syncopal attacks are though not uncommon, but should be very cautious in dealing with these conditions. Coming to the anesthetic technique, they're classified into local anesthesia infiltration technique, conscious sedation, and general anesthesia. Local anesthesia, which is most commonly performed by the dentists themselves, are some of the blocks such as inferior alveolar block, that is standard mandibular nerve block, also known as Halstead approach, or Go-Gates technique, or Vazirami Akinosi closed mouth block technique. These are the techniques which are administered by the dentist himself with the help of local anesthetic solutions with or without vasopressins. So commonly used are lidocaine 2% plain, effectiveness of analgesia, but the limitation is brief duration. Prilocaine 3% with felipressin 0.03 unit per ml can be used, but beware of can predispose methymoglobinemia and should be avoided in pregnancy. Articaine with epinephrine 1 in 1 lakh dilutions can be used, which is rapid in onset, less than 2 minutes, with exceptional ability to penetrate dense mandibular cortical bone and currently recommended for infiltrations only. However, most commonly used bupivacaine and ropivacaine, which prolongs the analgesia. Coming to the concept of conscious sedation. Conscious sedation is defined as a technique in which the use of a drug or drug produces a state of depression of the CNS, enabling treatment to be carried out, but during which verbal contact with the patient is maintained. Thus, the patient must retain their productive airway reflexes. Provider of conscious sedation should be adequately trained to deal with sedated related complications like cardiorespiratory compromise, and patient should be carefully selected and medically pre-assessed, and consent should be obtained, usually ASA 1 and 2, fit for conscious sedation. The principal techniques in conscious sedation are inhalational, intravenous, and oral. Inhalational. A titrated mixture of up to 70% nitrous oxide may be administered, and Entonox can also be tried. Clinical monitoring of patient color, respiration, and pulse is mandatory. Coming to intravenous sedation, this is commonly achieved with a titrated doses of benzodiazepines along with patient or target control infusion of propofol. More recently, alpha-2 agonists like dexmedetomidine can also be used under strict monitoring. Make sure that facilities must be available to administer oxygen or ventilation if at all needed, and patient should be adequately recovered and accompanied by a reasonable adult after completion of the procedure. Coming to the oral, midazolam or temimazam can be used, and monitoring and recovery requirements are same as IV sedation. In children, the sedatives like trichlorophos can be tried. Coming to the general anesthesia. Assessment. Patient should be assessed in the usual manner, particularly regarding their medical, social, and surgical suitability for daycare anesthesia. But wherever possible, avoid general anesthesia. If at all it has to be given, the risk of GA, general anesthesia, should be explained to the patient and consent should be obtained. Pre-medication, rarely required. However, short-acting benzodiazepines may be needed in uncooperative child. The general anesthesia mostly are indicated in the patients who are uncooperative, especially children, requires dental extraction. Emla cream can be tried to facilitate IV cannulation. Monitoring. Minimum ASA monitoring should be applied as required. Full range of resuscitation equipment should be available, and all equipment should be of standard equal to that used for the administration of anesthesia in any other settings. Induction, you can go with inhalational, IV, or intramuscular. Sevoflurane induction is preferable, especially in children, because of its quick onset and offset. However, an IV induction using propofol is a technique of choice at present daycare anesthesia. Coming to the airway. For simple exodontia, the airway has traditionally been maintained by means of a nasal mask. Two principal nasal masks are available, just Goldman and Meckizens. The airway is maintained by supporting the mandible with the fingers and preventing the tongue from falling back, while the patient may be allowed to breathe spontaneously through nasal mask. A pack is placed by dentist at the back of the pharynx to prevent aspiration of blood or debris. A gag or bite block is then positioned on the opposite side of extraction to open the mouth. For cases of extraction of wisdom tooth or any other more extensive dental extra procedures in uncooperative patient, the patient is generally intubated in operation theaters. The nasal route is preferred as this creates more room for the operating surgeons to work. Finally, the golden rule in dealing with upper airway is to intubate and protect the airway. Coming to the maintenance and recovery. Inhalational agents can be used, oxygen nitrous oxide, IV anesthetic agents can be used. Lastly, the pharyngeal packs should be removed and the pharynx cleared of secretions and debris by suction. Patient should be turned into left lateral position, possibly with a degree of head down tilt to encourage drainage of blood secretions away from the larynx. And the patient is adequately reversed from the neuromuscular blockade. Extubate the patient once fully recovered. They must remain in hospital until the usual criteria for discharge is met as a daycare procedure. Pain, nausea, vomiting must be controlled and there should be no continual bleeding. Coming to the analgesia, pain experienced will increase with the number of tooth removed, and for more extensive work, diclofenac or dexamethasone may help. Simple extraction, a single dose of paracetamol may be beneficial. Finally, the patient must be accompanied home by a responsible adult with clear instruction as what to do, should do once the post-operative complications arises.
Very good. Okay. So even though the question is worded here as anesthesia in dental chair, it does not mean that you always anesthetize the patient only in the dental chair, which most of you would have seen, which can be reclined and made even become parallel to 0 degrees. So normally the dentists like to keep you at about an angle of 45 to 50 degrees. And the chair can be made at to 90 degrees also with the back coming up straight. And it has the facility to go to 0 degrees also. But normally they keep you around 40 to 50 degrees tilt so that they can reach the oral cavity easily. And majority of the dental procedures, as rightly said, nowadays performed under local infiltration anesthesia administered by the surgeons themselves. But if they require the help of an anesthesiologist to anesthetize the patient for any dental procedure, the regular pre-operative assessment of all these patients should be taken, because you just not get a call, you just go there and give some drugs and keep the patient quiet and come back. That cannot be done. So you have to do a regular pre-operative checkup, and the patients who require anesthesia for extraction, not willing to have it under local infiltration anesthesia, are usually, as he said, children, especially those with learning difficulties, mostly autism children or children who are having OCDs. All those people only they come for, and their teeth are in such bad shape, they require multiple extraction in a single sitting. So these are the patients who will be required to be given anesthesia, or some adults who are very anxious and who are tensed, who are scared or needle phobic, as he said, who are afraid of any injections inside the mouth. Even for cataract, I have seen patients getting scared for any peribulbar or retrobulbar blocks. So even to administer that local infiltration, sometimes dentists use xylocaine jelly and make the gum and the mucous membrane numb, and then administer the injection to make the patient accept this and become more comfortable with that. Then, so the dental chair in the earlier days, as we trace the history, were done mainly under oxygen nitrous oxide mixture inhalation, delivered to the patient through the nostrils by the so-called dental mask, which is covered only the nose and patients were taken to the surgical plane of anesthesia with that, and one or two extractions can be easily done because the nitrous oxide has got a good analgesic property also. But nowadays that is become very obsolete. Nobody uses those masks and only nitrous oxide. So if it is going to be anesthetic required for that, you must inform the patient to be adequately starved. That is a very, very important criteria. So you must tell the dentist to instruct the patient not to have any solid food, follow the same fasting guidelines of 6 hours of abstinence from solid, 4 hours from milk, and 2 hours for clear fluids. All that instruction should be given. And because it's a daycare procedure, we don't prefer to give any oral pre-medication prior to administering full general anesthesia. And one more thing in this point of local infiltration technique, in those days they used to have what is called the dental cartridge, which used to have 2% lignocaine with 1 in 80,000 adrenaline. The concentration of adrenaline in the dental cartridge used to be quite high. So patients, adult patients who have hypertension or ischemic heart disease, or patients with arrhythmic tendency, they may all have violent reactions because of that high concentration of adrenaline or epinephrine that is present in that. But it prolongs the duration of analgesia. At the same time, it also reduces the bleeding. So dental surgeons were using it for a long time, but nowadays I don't see any dental surgeon using those cartridges. There used to be.
So it's still there, sir. Cartridges are still there, sir.
Yeah, but
still
modern
there,
dentists to whom I go, they are all using the regular.
Articane cartridges have come now, sir. Articane one is
Articane. Okay.
That has come as cartridges, and one is lignocaine with 1 in 80,000 adrenaline.
Adrenaline, yeah.
That's what they use.
That actually, used to be the thing. And majority of the dentists do not know the side effects of epinephrine. So they use 2 or 3 cartridges at a time, especially if it is a cross-impacted wisdom tooth, which may take even 1 hour, 1.5 hours to extract. So they use 2-3 cartridges which will contain about 2-3 ml of this solution. So the total dose of epinephrine may be quite high. So that is one precaution that you have to make sure that you don't allow them to use that excess quantities of those drugs. And when it comes to administering GA, it cannot be done in the dental chair. So you have to shift the patient to a regular OT table and then have all the facilities for injection and nasal intubation. And some Western centers, they use a flexometallic LMA also for instead of intubating through the nasal route endotracheal intubation. They administer or advocate usage of flexometallic LMA and keeping a pack, because it will reduce the post-operative coughing and bucking and all those things. So that is another point that you may add to your description. So otherwise, I think it is a fairly very well prepared answer. Thank you.
Yes, sir. So one important thing is he was talking about bupivacaine and plain lignocaine. They never use, sir.
They don't use
bupivacaine or plain lignocaine. It is always lignocaine with adrenaline, 1 in 80,000. However, whatever the patient has. Another important thing is the duration of the procedure. Sometimes they start with just a few extractions and a few fillings, but then they find something else. They speak to the patient's attenders, relatives, and it just goes on for 2-3 hours sometimes. And if patients have some medical problem and they have to keep their mouth open for so long with their head extended and all that, it becomes a big problem. They have had deaths on the table. They had dental deaths, just hypertensive patients, things like that.
Yeah, we had
very careful when you go for conscious sedation for these patients.
Year, I think in the papers.
It happened even recently. Even last happened to a
last year.
So these things keep happening. So you have to be very careful when you go for conscious sedation in a dental chair. Do not take it lightly at all. It is just local or conscious sedation. You must have all the backup No general anesthesia can be given on the dental chair. Like sir said, it has to be only in the theatre. And do not compromise on the airway, even if the shortest of procedures, intubate. Put the nasal tube, intubate, because you never know what the surgeon will do. And if the tooth just slips off his forceps, which has happened, it will go and fall on the faucets, and it becomes very, very difficult for you to pick it up. So these are some things which happens in the dental chair. And when you're doing it under local, you can have anything. So monitor the patient very, very closely. Must have usual, all the anesthesia machine, oxygen, all the resuscitative equipments must be there. Dentists will take it lightly because they do not know. Many of them do not know. But if you go to a proper center, everything will be there. So that is the way it should be set. So as if you're starting off as a junior, if you're starting off, make sure that you are safe and that your patient is safe. I do plenty of dental conscious sedation, so I know what is happening. And over the years, how much we have fought for all these safety gadgets. It will never be there. You will have a laryngoscope which will not burn, the usual things that happen. So don't fall for it. No GA on the dental chair, that's for sure. And they will always use lignocaine with the adrenaline. It will never be plain lignocaine. But why don't they use plain lignocaine? Can you tell me? You said short duration, but there's another reason to it. What is lignocaine? The blood
Bleeding,
vessels?
madam. Vasoconstriction.
Bleeding.
Bleeding will be reduced with lignocaine with
adrenaline. If you use plain lignocaine, they will ooze a lot.
As bleeding the problem.
Lignocaine with adrenaline. Okay, so that's something to keep in mind. Yeah, don't even mention GA on a dental chair. It's never given.
Okay.
Using nitrous oxide, all that is quite useless. It's just it has to be either midazolam, Texmed, and a good block, and even that with close monitoring. And if you are if you have all the equipments, then you can probably give small doses of propofol if you have the full backup. Otherwise, it's just Texmed and midazolam most of the time.
Thank you. Shall we move on to the next topic of yours?
Second topic, complex regional pain syndrome. The topic is divided into overview, classification, causes, pathophysiology, diagnostic criteria, and management. Coming to the overview, chronic regional pain syndrome, CRPS, is any of the several painful conditions that are characterized by continuous, whether it is spontaneous or evoked regional pain, disproportionate in time or degree to the usual course of any known trauma or surgery or other lesions like heart attack or stroke. Usually, pain resolves as the body heals, but with this condition, pain doesn't fade with time. Instead, ongoing pain might get worse as the day passes. It is classification. CRPS is classified into two types, CRPS type 1 and CRPS type 2. CRPS type 1, also known as reflex sympathetic dystrophy or Sudeck's atrophy. CRPS without evidence of nerve damage in the affected limb is classified as CRPS type 1. It is usually due to secondary to injury or trauma, accounts for 90% of cases. CRPS 2 is causalgia, which shows a evidence of nerve injury in the damage in the affected limb. Causes. Though this condition is uncommon, CRPS typically developed after an injury or surgery. Investigators estimate that 2 to 5% of those with peripheral nerve injury and 13 to 70% of those with hemiplegia may develop these conditions. Some studies have indicated that cigarette smoking was strictly present in patients with CRPS. This may be involved in its pathology by enhancing sympathetic activity and vasoconstriction. Coming to pathophysiology, has not yet been fully defined. It could be a result of multiple pathophysiological processes, which include inflammation, alteration of pain perception in CNS as a important roles, which play an important roles. Perception of non-painful stimuli as a painful are thought to be caused by the inflammatory molecules like interleukin 1, 2, tumor necrosis factor alpha, and neuropeptides like substance P released from the damaged peripheral nerves. This release may be caused by inappropriate cross-talk between sensory and motor fibers at the affected site. The other pathophysiology include vasomotor dysfunction. So there will be problems with blood circulation causing swelling and discoloration of the affected limb. Compelling evidence show that NMDA receptors have a significant involvement in the CNS sensitization process. The other thing is sympatho-afferent coupling, which means in neuropathic painful condition, neuronal activity in sympathetic efferent nerve fibers may cause excitation in somatic efferents. This coupling may sometimes contribute to the ectopic activity of the lesioned or unlesioned efferent, especially in CRPS2. Diagnosis. Diagnosis is primarily based on the clinical parameters. Women are twice as frequently affected. Typically, symptoms are preceded by history of trauma. As the trauma area heals, patients who develop CRPS are left with persistent pain that has the characteristic of neuropathic pain associated with signs and symptoms of dysfunction of sympathetic nervous system like swelling, edema, erythema, or bluish discoloration, temperature asymmetry when compared to the contralateral limb. Some clinical diagnostic criteria by Budapest was given, which include continuing pain which is disproportionate to an inciting event, must report at least one symptom in four following categories, such as sensory, vasomotor, pseudomotor, and motor. Sensory include reports of hyperesthesia or allodynia, that is, even for a pinprick or touch sensation, these patients may develop exaggerated response. Next is vasomotor response. Reports of temperature asymmetry or skin color changes, and pseudomotor response or sweating asymmetry. Motor response include reports of decreased range of motion or motion dysfunction, such as weakness, tremor, dystonia, or trophic changes including the hair, nail, and skin. There is no other diagnosis than better explains the signs and symptoms. No specific test is available for CRPS, which is diagnosed primarily through the observation of symptoms. However, thermography, sweating test, X-ray, no osteoporosis changes, electromyography test are present. Diagnostic sympathetic blockade can also be tried to support the diagnosis of CRPS. Coming to the management, CRPS can lead to long-term severe persistent pain and loss of function related to loss of use of painful extremities. So early therapeutic intervention is desirable and prevent the transition to chronic CRPS. Multidisciplinary treatment, including rehabilitation team that include a provider that overall sees the medical management, working in close coordination with a physical therapist and a psychologist, appear to be the most effective means to help this group of patients. Patients often fear the transient increase in pain and exacerbation of visible symptoms with the use of the affected extremities. So reassurance and pain reduction can facilitate functional restoration. Coming to the medical management, bisphosphonate treatment can be tried. Evidence support use of bisphosphonate either oral or IV. It inhibits the osteoclast involved in resorption of bone. Bone resorption may be increased in CRPS, which can be prevented with these bisphosphonates. It is hypothesized that bone resorption causes acidification of intercellular milieu, and this activates nerves involved in nociceptive pain. Coming to opioids. Opioids such as morphine, fentanyl, ketamine in low dose can be tried. Buprenorphine patches should be prescribed under close supervision as they may lead to addiction and physical dependence. They should be only considered if all the medications such as non-opioid, physical therapy and procedures have been tried. Vitamin C may sometimes useful in the prevention of CRPS. Coming to the interventions, spinal cord stimulators can be tried to treat CRPS. The spinal cord stimulators appears to be effective therapy in type 1 and type 2. Dorsal root ganglion stimulation is more effective than dorsal column stimulation. Second important modality is TENS, transcutaneous electrical nerve stimulation, which uses low voltage electrical signals to provide pain relief through electrode placed on skin surface. Next option is sympathectomies, which may be surgical, chemical, radiofrequency, stellate ganglion block sympathectomies. In this process, interruption of the affected portion of sympathetic nervous system can be used, which as a last resort in patient with impending tissue loss, edema, or recurrent infections or necrosis. Finally, amputation. On average, about half of the patients will have the resolution of their pain, while half of the patients may develop phantom limb pain. As any other chronic pain syndrome, the brain likely becomes chronically stimulated with pain, and a late amputation may not work as well as it might be expected. Since this is the ultimate treatment of a painful extremities, it should be left as a last resort. Coming to the prognosis. Prognosis will be improved with early and aggressive treatment. If treatment is delayed, it can progress to entire limb, and changes in bone, nerve, muscle may become irreversible. Prognosis is worse with CRPS affecting the upper extremities. Some cases may resolve spontaneously around 74%, but other may develop into chronic pain for many years. Taking precautions and seeking immediate treatment upon any injury is important.
Okay. Very good. Formerly, this condition was called as chronic regional pain syndrome only. But later they modified the name into complex regional pain syndrome because of the various pathophysiological theories that were propounded for the occurrence of this particular condition. So that is basically divided into CRPS1 and CRPS2. And the important point you have to highlight in your answer is in CRPS1 there is no direct nerve injury is present. It is an injury elsewhere from which the patient starts feeling a severe degree of pain. Whereas in CRPS2, there is a direct injury like a brachial plexus injury in following a road traffic accident, especially two-wheeler high-speed accidents, or a forearm fracture where a nerve entrapment has happened, especially radial fixation of humerus. Many times the radial nerve will get entrapped in the plating, and it may immediately produce a wrist drop, but later on the patient may go on for severe pain also. So the CRPS2 primarily has a nerve injury, primary nerve injury also to result in a chronic sustained post injury pain. And the two terminologies that you have to include in your answers is allodynia and hyperalgesia. Because whether it is CRPS1 or 2, the main important thing is the allodynia, which is the pain following an innoxious or a not noxious stimulus, and hyperalgesia is a pain which is exaggerated even for a minor nociceptive stimulus. So these two terminologies have to be included in your answer to indicate the severity of the pain. And it is a chronic state of pain that many times is not completely cured. The statistics that show that many patients with CRPS never get 100% relief in their lifetime. So they have some amount of residual pain, and over a period of time they get used to that pain and start living with that. And as anesthesiologists, we were initially involved in the administration of blocks like stellate ganglion block or lumbar synthetic block for relieving the pain caused by the vasomotor component of that by causing a vasodilatation and relieving the ischemia. But later on, now many of us or even the non-anesthesiologists take up pain medical as a specialty. So pain physicians have now taken over the treatment of these conditions. So unless you also become a pain physician, as an anesthesiologist, the cases referred to you for a block may be coming down in future. But as with older day anesthesiologists, we had a lot of references coming for giving a stellate ganglion block and lumbar plexus block, all these things by the usually from the orthopedic surgeons. They only refer these cases. Now the pain medicine having become a specialty by itself, this will be under the purview of these physicians in future. But you must have a basic knowledge of all these things, and initially you try pharmacological methods like any chronic pain, and then if there is not a satisfactory relief, then you go for the blocks and other interventional therapies. So all these points have been very well described by Venkat, and that's I think a fairly nice answer for the question.
Very nice. A very nice presentation, sir. Sir, did he mention intravenous ketamine, sir?
Yeah, he mentioned low dose ketamine.
Low dose intravenous ketamine. I missed it, I think.
Yes, he mentioned that as a one of the treatment pharmacological methods of treatment.
Pharmacological, okay. Steroids and okay. Yeah. Maybe clonidine also, no, sir. Nowadays they use some clonidine also.
Yeah, Dexmed, clonidine, all these things are also being used. And of course, he mentioned about buprenorphine patches, and local xylocaine patches are also being used nowadays. And xylocaine infusions and magnesium sulfate infusions are also. Okay. Can you go to the third?
Yes, sir. Third topic is Glasgow score in pancreatitis.
Yeah.
Acute pancreatitis is the inflammation of pancreas. Causes in order of frequency include a gallstone impacted in CBD, heavy alcohol use, trauma, systemic disease. Mild cases of pancreatitis are usually successfully treated with conservative measures like hospitalization, pain control, nil by mouth, or IV fluids. Severe cases often require admission to ICU to monitor and manage complications of the disease. Some may develop abscess, pseudocyst, duodenal perforation, ARDS, and DIC. So classification of severity, the prognostic scoring system are Ranson score, Apache 2 score, Glasgow IMRI score, BISAP score, Balthazar score. But today topic of discussion is Glasgow score. The Glasgow score is valid for both gallstone pancreatitis and alcohol-induced pancreatitis, whereas Ranson score is only for alcohol-induced pancreatitis. It is scored through the mnemonic pancreas. P stands for PaO2, which is less than, if it is less than 8 kPa or 60 millimeters of mercury, 1 point. Age more than 55 years. N stands for neutrophilia, more than 50,000 units per microliter. C stands for calcium, less than 2 millimoles per liter or less than 8 mg per deciliter. R stands for renal function, that is urea, more than 45 milligram per deciliter or more than 16 millimoles per liter. E stands for enzymes, that is LDH, more than 600 international units, or AST, more than 200 international units per liter. A stands for albumin, that is less than 3.2 grams per deciliter. S stands for sugar, that is blood glucose, more than 180 milligram per deciliter or more than 10 millimoles per liter. If the patient score is 3 or more, it indicates the severe form of pancreatitis and should be considered to transfer to ICU and close monitoring. That's it.
Yeah. So it is this sharing is for assessing the severity and the mode of management mainly. So milder cases can be just conservatively treated, as he said, but the nil by mouth concept is slowly changing. In milder cases, they say that olden days, they in fact used to put a nasogastric tube and aspirate the stomach and keep it totally empty. But they found that translocation of gut bacteria into the systemic circulation and going in for sepsis is much higher if you keep the patient nil by mouth for more than 48 hours. So what they nowadays do is they have starting enteral feeding as early as possible, is the present day concept. But based on the Glasgow, this is also called modified Glasgow scale, Imri scale. Because based on this, what you do is you have to go for what is called the CT severity index, where you are more worried about the necrosis of the pancreas. So the pancreatic necrosis may progress for a week or 10 days, and then it is self-limiting, it will stop. The CT severity index, you may have to sometimes do a laparotomy and excise all the necrotic tissues. So that also has to be taken into account by using this Glasgow score. So the severity depends or has a very important bearing on the outcome if they have to undergo for a laparotomy for excising the necrotic pancreatic and other tissues. So all the, it will ultimately result in what is called the multimodal, multidisciplinary or multi-organ dysfunction, MODS. So that is what we are worried about. So that is the reason why the scoring is very important. To even if we treat them conservatively, the chances of all the various systems getting affected is more if the score is very high. So that is the reason why you have to use this scale to. So it's a very short answer only. So you don't think that you have to write pages and pages for every question. So whatever relevant points, if you write, that is more than enough if it is asked as a short question.